Good afternoon, everybody. According to my clock on my computer, it's now 1:30, so we'll make a start. Can I just remind everybody to have your mics on mute when you're not speaking, which I can see you all have, and also for people, if they don't mind, please turn on their cameras, because it does make life a bit easier for me rather than looking at a blank screen when I'm trying to talk to you all. That would be most helpful. We just starting off this afternoon, we have apologies from Fiona Theoden from NHS E&I. There's no representation from them today. Kath Byford, there's no representation from the LMC today. Mark Burgess, Kerry Overton, and John Webster. So that's all the apologies that I have. And thank you for everybody else who are here and attending. On to declarations of interest, I just remind everybody to keep their register of interest updated and let Sarah know if there have been any changes. And can I just ask whether there is anybody who has any conflicts in any of the agenda items in part 1 of this meeting? There's no hands up, so I assume there aren't any. Thank you very much. Moving on to the minutes of the last meeting, which has been circulated. I will take it as read. Are there any corrections for factual accuracy? No. So I don't have any either. So we can take the minutes as approved, and I will sign them in due course. Are there any matters arising that are not on the agenda? Anyone want to raise? No, thank you very much. Moving on to the action log. All the items are marked as blue and actions have been closed. I think there was just one item on the minutes of the last meeting that's not captured on the action log, was a report back on the training hub in the next workforce update. Could we just add that on so it's tracked, please? Thank you. Move on to the forward plan, and you will notice that one of the items that is due for this month's meeting is not included in the paper. It's a deep dive for severe mental illness health checks. I think this is going to be picked up at a later date. Do you want to just confirm that, Sadie?
Yes, hopefully you can see are things that we aren't bringing on their due date, and the explanations for why that is are below.
Thank you very much. I think before we move on, actually, I just wanted to, obviously there's a lot of work going on behind the scene for the staff team dealing with COVID and the level 4 for the NHS at the moment as well. So we are trying to keep the meetings going, but we're going to keep the agenda as tight as possible to release executive time to do their day job. So please bear with us in the next few months whilst things go up and down a bit within our support and staff workload as well. Moving on to the risk register. Do you want to just talk us through that to begin with, Sadie?
Thank you, Doris. Yes, of course. You'll see from the summary top sheet that we've got 2 risks highlighted in bold for you there. Oh, sorry. About the background noise. So the first risk I'd like to highlight is PC4. And I'm very pleased to report there that there's been a reduction in the risk rating. And this is because we have managed to secure the extended hours position across all of our localities, and the extended access specification is now being delivered. We have 111 direct booking capability in place already, and Parveen's team at the time of writing had agreed the improved access position for 4 out of 5 localities, with the final plans being developed. Parveen, I don't know if there is an update today to that.
So the south locality, a couple of the PCNs, so they have their plans in place and they're ready to go. Unfortunately, we've just had some technical difficulties in terms of the IT infrastructure, and we're hoping those will be resolved by next week.
Lovely, thank you. So with any luck, we'll be able to further reduce that risk for the next meeting. The other risk, which I was going to highlight to you, unfortunately, seems to have dropped off the end of the register. It was a new risk, PC13, and as you can see, we stop at number 12, and for some reason it looks like the document has corrupted. PC13 is a general resilience risk for primary care, which we have added this month following some discussion in the part 2 meeting at the last committee date in October. And this is largely down to workload and workforce issues that are affecting general practice, but also at the present time, as everybody is aware, some of the issues relating to working in a COVID secure way and having staff that are affected by the pandemic. So we have added that new risk onto the end. We'll make sure it's on there for next month. We'll circulate it outside of the meeting. So apologies that it hasn't formed part of the written documentation today. But those were the 2 that I wanted to highlight. I'm very happy to try and answer any questions or refer to colleagues here at the meeting if committee members have any questions or queries.
Can I open up to questions from anybody? Hein?
Thank you, Chair. I had a question on PC13. So it was mentioned on the summary, Sadie. So it piqued my interest because potentially it's a very serious risk in terms of its impact. But I saw the impact was given a 3, and without getting too technical, if 3 becomes a 4, it's quite a serious situation. So can you share some of the thinking behind where you've assessed the impact and what actions are being taken to prevent it going one notch further?
Sure, but sorry, I'm just trying to scroll in between my screens. If you just bear with me a second. So we'd scored it at 4 by 3, which is a significant risk. As you know, consequence major 4 and likelihood possible 3, which gives it the scoring of 12. I think
the other way around, the way I read it, but I'm happy to be corrected.
4 by 3.
I thought the likelihood was 4 and the impact of 3. But maybe I misread it.
I might. My intention was to score it 4 by 3, which was major impact by possible likelihood. I'm sorry if I've got that the wrong way round.
But that puts my mind somewhat at ease already. So maybe on the next occasion we have a chance to go for it. But that already helps, Sadie. Thank you.
Yeah. So the impact, of course, would be very serious in a particular area. although what we are now seeing, all of the practices are doing a huge amount of work on business continuity planning within their primary care networks. And indeed, we've seen that being put into action on a number of occasions over the past few weeks, as practices have had to enact that when they've had, for example, a member of staff testing positive and have had to take a number of actions as a result. We, in terms of the likelihood, it is possible at the moment. We are seeing some business continuity incidents. Practices have done a fantastic job of coping with what is being thrown at them at the moment, as well as keeping services open to patients. And in the last week, we saw a practice that enacted their arrangement with their buddy practice just down the road, who provided them with space should they need it. They didn't actually need it in the end, but it was all put into place very quickly as a result of the arrangements that are put in place. So I think at the moment what we're seeing is obviously practices working under a great deal of pressure, just like all other health providers are at the moment, but coping really, really well with it.
Thank you.
Are there any other questions, John?
Thank you, Chair. I just wanted to ask about risk PC6, if I may, because conscious it's a red risk, but still red. This is about health checks for patients with learning disabilities. And the commentary suggests that the programme has been paused because of the COVID pandemic response, which makes eminent sense in terms of the pressure on general practice, but also conscious about a vulnerable group of patients and the need to protect inequalities during this time. So I'm just wondering,
Yes.
how we're trying to balance that.
This is one of the high priority areas for recovery, as set out in all of the national guidance. It was certainly paused in the early stages of the pandemic. I think the challenge for practices is that they can't mark a health check as complete until they've done the physical check. They can do lots of the elements of the health check remotely, but the physical check is required in order to have completed it and therefore count it and report it in our numbers. And that's proving challenging at the moment for obvious reasons. There's a nervousness, particularly now that people with learning disabilities have been added to the clinically extremely vulnerable, previously called shielding list. So I think there's a lot of concern around that. What we have seen overnight is a letter published from NHS England, which is providing some additional funding to systems to support capacity in general practice. And we should be getting just under 3 million in Norfolk and Waverley. And one of the priorities highlighted within that is the ability to undertake LD health checks and reach the 67% target that Parveen told us about at the last meeting.
Can I, sorry, just following up on that then, Sadie, that sounds welcome, but I don't understand how that solves the problem of it being difficult to bring patients who are clinically extremely vulnerable into a practice for the health check, even if we've got all the money in the world.
Yeah, I don't think it does solve it. Parveen, you've got your hand up.
So I'm just unmuting myself. Thank you. So, John, you're absolutely right. A lot of these patients are shielding, and what we're hearing back from practices is that they're struggling to get these patients into general practice. And as Sadie said, unfortunately, NHS England won't allow us to show it as a completed health check unless the physical elements have been done. However, what we are now trying to do is improve performance and uptake through the care homes DES, LCS. So for the first time this year, LD care homes are actually included. So we're now trying to get practices to focus on carrying out the health checks in the LD care homes and also some of the other specialist care homes to try and make up the target to the 67%. And we also have some initiatives in each locality around a peripatetic team that perhaps could do some home visiting. And again, where we've got home visiting teams in each locality, we're saying if you're out in the patch, can you please try and see whether you can increase your LD health checks at the same time. So we are trying everything, but it is a challenging environment. Thank you.
Bill?
Thank you. Just following on from John's question, is this very similar across the whole of the area, or do we have pockets of really good practice? I mean, we can't get a sense from this whether it's, and if there is there any learning that we could then take from that?
Parveen, do you want to come in on that one?
Thank you. Unfortunately, the pattern, the issues that we are experiencing in Norfolk and Waveney is no different to the national picture. So we have, so there's a national platform, and we have actually raised queries there.
Join the meeting.
On whether anybody's doing anything innovative or if they're doing anything different. And the only feedback that we've had so far is that you can do almost 70% of the health checks by either telephone or online or virtually, but it still doesn't get over the problem that unless you complete those 3 physical elements, it still doesn't get classed as a completed health check. So we are on the national platform consistently asking colleagues, but it seems to be everybody's asking the same question, whether NHS England will relax some of that criteria, we just don't know at the moment.
So do we have data in terms of the ones where there's been a partial completion of these health, where we are, if 50% is partial, and then at least we kind of have a bit of a handle on how far off, how much we're waiting for the physical bit.
Unfortunately, the way that the system works, they can't run the report until it's completed as a completed health check. But a colleague in my team is actually ringing around. So we've just the last fortnight ago we had the latest data from NHS England. So a colleague in my team is now actually ringing around practices to see where they are in terms of completions and what other support we can give them. But at the moment we can't. The only data we can draw down is the completed health checks, i.e. the fully completed elements.
Yeah, because I think actually it'd be quite useful just to have some of that information, because then we can go much easier to argue your case when you go, this is what the practices are actually telling us in terms of the partial completion, rather than, it's just that feeling rather than lack of statistics.
Yeah, we're happy to go back out to practices, but it'll probably be a manual adjustment. So completed health checks we can pull from CQRS, which is the NHS England payment database. If it's partial, we'll probably need to go back to practice for a manual adjustment. And I'm just conscious over the next couple of weeks if the COVID vaccination, it's trying to balance it against other priorities. But we're happy to look into it and feedback for the next meeting.
But it could be that actually, it's just having I don't know whether, there's a simple thing that practices go, we have 50 on our books or 10 on our books that are partially, and actually, that's probably all we need, isn't it? James, I'm sure you can enlighten us with reality.
Well, I just wanted to offer a slight comment, really, which is it's not just the COVID-related incidents that we have here. We were starting to think of a different approach. Part of the thing is that you're offering an interventionist white coat approach to people's in their whole scale life, and it's not necessarily an appropriate way to offer a service from that point of view. The way that the take-up was pre-COVID was always difficult. I'm sure Rosemary will back this up. We always have difficulty engaging with these patients because it looks like, if you're familiar with one flew over the cuckoo's nest, a Nurse Ratched style intervention in people's lives that's not immediately relevant. And I think we need to look at a service that breaks it down, offers it, connects it with social prescribing, and design something that makes it look as if it's a supportive, helpful intervention in people's real lives, rather than designing it as a clinician protocol intervention, because people, that's the journey that I think we need to get to. There are some particular challenges over the next few months that we need to get to as far as COVID is related. But I think that's the thinking. We had some ideas that we're going to do, but clearly we've had to can those because of COVID. But that's where I think a conversation needs to go, which is how do we explain ourselves and insert ourselves relevantly into people's lives, and then they will gladly come. At this moment, it looks like an intervention that isn't welcome.
Thanks, James. I think that's very helpful. I think there's could be quite a lot of nodding around the screen that I can see, because actually it's about personalised, really about personalised medicine, and actually, what the patient needs rather than what we want to do to them. Rosemary, did you want to come in on this?
Oh no, only just to agree with James. It's always been a really challenging area, even pre-COVID, to get these done and to get the patients in. And it just sometimes just seems like completely the wrong approach. Just the whole setting and the way it's designed is just difficult, very.
Thank you.
I also would just say that, just speaking from a general practice point of view, having just received the information on the COVID vaccine as of today, I'm not quite sure the reaction you'll get, Parveen, to requiring data around learning disability checks just at the moment. I'm just not quite sure how receptive practices will be to that.
No, I agree. I think we'll try and see whether we can pull anything from the centre. Yeah. But at the moment, I'm ringing 105 practices to try and get partial. It's going to be a challenge.
I think there are some slightly other priorities just at the moment, particularly this week, to be fair.
Terry, did you want to come in?
Yes, sorry about that. I've got dogs barking. I was just letting them stop. I don't think we need worry too much about vaccines. I think because the temperature, they've got to be kept at. I don't think many GP practices will have fridges or freezers that keep below 80 degrees, minus 80. I think the plan is, the way it's going at the moment, is the mass testing in Liverpool, and it's moving out to other places. I think they'll be looking at doing mass vaccinations in a similar way. I might be wrong, but that's just what I'm hearing.
Thank you. I just had a question on PC3 it was just really because on the commentary within the risk register, there's the phlebotomy service in Cromer was cited, but I thought that is now resolved with the new arrangement that has been put in place. And if that is the case, could the risks be just reviewed for next time?
Yes, certainly. We understand that the Cromer service is doing very well and it's really settled very well. So yes, we'll have a look at that for next time. Thank you.
That's great. Thank you very much. Are there any other questions on the risk register from anybody? No, it was really good to actually have a debate about the risk register. Usually we are met with deathly silence, so thank you all for your contribution. If there's nothing else on the risk register, I'll move on to the finance report. I'm not sure who's taking this one. Is it John or Jason? Jason. Thank you.
Thanks, Doris. Before I launch into the report, I'll just give a bit of background for the month 6 reporting. Within month 6, we've actually received notification of the allocations for the remainder of the year. So a lot of the variance analysis within the report, if you try to tie it back to previous months' reports, you wouldn't be able to, because we now have the actual figures. So this report has been updated for the actual figures that we now know we're going to receive. So that's just a bit of a health warning. Just as a general overview, the year-to-date overspend is 4.85 million, and this is mainly driven by the month 6 top-up. We receive top-ups retrospectively, so the majority of that 4.85 million was anticipated to be received within the month 6 top-up, which we are still waiting to receive. and the forecast outturn for the end of the year is an 850k overspend. Therefore, the report is focused on the forecast outturn predominantly. Since writing the report, this has partially been mitigated, and the current month 7 position is an overspend of 554k. The change is predominantly due to improvements in the prescribing area. Driving the overspend in this month's report, however, is the GP out of hours and the NHS 111 services, which have a combined variance of 740k, and this has been driven by the new contract, which is a 24/7 contract, and the cost of transition to that contract due to the delay in implementing the new service model, which is being underwritten by the CCG to enable the continuity of service. In addition, there is just under 100k within delegated primary care, which is predominantly driven by rate increases within the practices. Moving on to the COVID spend, year-to-date COVID, we've had 7.5 million of expenditure, and the forecast outturn for the year is 12.9 million. However, as of month 7, the finance regime for COVID reclaims has changed, and this is now not on a reimbursement basis. We've been given a fixed element for COVID costs for the system. With regards to the amount of spend that we have claimed, the most significant element remains staffing costs for locum cover for ill and fielding staff, and also the cost covering the costs of the bank holiday opening. Regarding the practice by practice comparison, which has been commented on previously, this now goes to Finance Committee for scrutiny in addition to current year. Finance risks represent the high-level summary of the risks, and the focus remains for the rest of the year to close the forecast overspend and mitigate that forecast overspend. Could I open it up for questions?
Are there any questions from anybody on the finance papers? Hein?
Thank you, Chair. Jason, the full year allocations that were received for the reapportionment, is that more out of curiosity question after heavy negotiation, or NHS England recognizing the ability not for the CCG but maybe something they've seen across the board? Can you give any sense on how it came about?
We've been given the allocation that they've come up with. It weren't really a negotiation to get the numbers that we've got at the moment. However, there is a process, not specifically within primary care, but more wider for the system, not just the CCG either. And I think John probably alluded to this as well. There is some discussion ongoing with the regional team, and the regional team, I believe, this week are having national discussions with national teams, and any feedback, there'll be a bit of a feedback loop in terms of questions being raised and clarifications, specifically linking back to the month 6 top-up that I referred to earlier as well. So
okay,
I wouldn't call it negotiation.
Okay, thank you.
John?
Thank you, Chair. I just wanted to make one comment, which was the report includes details of COVID-related expenditure that we've reimbursed through to practices or supported practices with. Just wanted to emphasise the fact that the national guidance states that there's an expectation that there's no further reimbursement to practices after the end of September. However, we're very conscious of the pressures on primary care in Norfolk and have made an allowance within our planning going forward for a relatively small amount, but an amount to be able to cover some of the ongoing pressures that are there. So there's very tight criteria that apply to that, but we thought it was important to be able to recognise some of those things that are coming through.
Thanks, John. So I assume that the forecast outturn for the COVID expenditure includes that element that we've set aside to cover future costs.
Yeah.
Thank you. Are there any other questions for John and Jason on the finances? No, thank you very much. Thank you. We move on to the paper on the digital update. I think Anne's just joined us, or she, yes, I can see her. Hi, Anne. Would you like to give a sort of brief summary and then we can open up for discussion?
Yes, I can. So I have described in the paper the focus of our work at the moment on the digital first primary care initiatives. This week we've been focusing on the wave 2 preparedness, of course, because of the new lockdown. So we've been getting in touch with practices to ensure that their mobile technology is still working, and encouraging people to log on and check their PIN codes and access haven't expired if they haven't used the devices for some time, and have prepared guidance on quick adoption of Microsoft Teams and Sharepoint, so that practices can effectively take the office home and have access to their files and folders, which currently the remote access doesn't give them. We've also seen a big upsurge in care homes asking for support for video consultations. So that's a bonus, really, and that they're encouraged to adopt the technology and access the training and support that's available to them. We know that around 50 care homes have also taken advantage of the NHS offer for iPads and are expecting additional devices and some training through that route as well. So that's been our focus really over the last week or so.
Thank you. So you've not been busy at all then? Tracy.
Sorry, apologies for being late. I did have digital issues, so I had to change venues from the practice to get home to get on. So my question, Anne, is I think with our kind of digital first approach, I think there are challenges in primary care still, I think particularly with footfall, and I'm just keen to know how we're kind of supporting. I've just come from a practice where we're absolutely inundated with them today, and it's a 24/7 constant, strive to get through them and keep on top of them. So it's just, what some of that work are we doing in the system to support, our practices? Certainly think about everything that's coming online over the next potential months with the COVID vaccination, etc. So just some thoughts around that, really. And I just think that clarification about the video consultations and what's the recommended kind of approach. And we have one or two kind of different systems in operation at the moment, and I know that's something that we have Accurix, we have obviously Footfall. So it's just what our thoughts on how we manage that as a system as well.
Okay, so Footfall first of all. So we are aware, Tracy, that some of the practices, in the main, those that took Footfall as part of the rapid rollout during the first lockdown, are experiencing difficulties, and that's because they didn't have the advantage of undergoing the transformation. So we are offering them transformation resources to work through their processes and have things set up better. We've also worked with Silicon Practice to develop the ability to switch the forms off. NHS England say that there must be an approvals process for this, so practices have to be experiencing such demand that it presents a clinical risk, or they might be suffering from an issue such as staff absence or an IT outage, but we just need to work with the primary care AD team to ensure that there's a clear process for practices to request the switch off. So the technical abilities there, is just the process around it. And we've got a couple of practices just testing that technical ability for us now. We're also, sorry, working with Silicon Practice on the sorry about that, on the integration with the clinical system, which I know is causing a lot of issues as well. Excuse me. In respect of video consultations, the AccuRx central funding has been extended until the end of March with the Wave 2. We haven't yet done any work on the procurement of a different system, so people can continue to use AccuRx, Footfall, or Microsoft Teams.
Are there any other questions for Anne? Terry?
It's nice to know we're moving towards a digital age with GPs, etc. But that, do the services and the networks that you're using, how do they link into adult social services and social workers?
So we are all now on the health and social care network, and we all have the same provider that was procured across the whole system. We are also all moving towards having the Office 365 suite of products. At the moment, each organisation is on its own tenancy. There are a team working to bring all those tenancies together so that eventually, in a year or so, hopefully, we will be on a single tenancy across the whole of health and social care in Norfolk, certainly. I'm not sure about the Waveney part, but certainly in Norfolk.
Well, it was the Waveney part I was concerned about.
Yeah, I'm just not promising that. I can't. I'm not sure if the social care part is will be on Suffolk's tenancy.
But we need to, I hate to harp on about this, but whilst Waveney remains in Norfolk CCG or ACS, however we wish to term it, it must be included in any form of digital move forward, because you have 165,000 people to look after.
I think we would agree with you on that one. John?
I was just going to say, Doris, looks like Anne's dropped off the call momentarily, but I completely agree with what Tony's saying, and our digital initiatives do absolutely embrace Norfolk and Waveney. I think the complication here is about the Suffolk County Council overlap and interaction, but absolutely make sure that we do get that link up as well with Suffolk County Council.
Thank you.
Just Anne's dropped off the call, but somebody else might be able to answer the question that I have about where practices haven't adopted Footfall. Are the patients registered to those practices disadvantaged in terms of access to primary care? Because it's not a sort of adopted across the board.
Doris, I think yes, in a word, and appreciate that not all patients will find Footfall their preferred mode of accessing practices, but for those that do appreciate the flexibility that it gives, yeah, the patients are disadvantaged at the practices that haven't yet adopted Footfall or online consultation system. So there is still work under those few practices that aren't yet signed up to Footfall, just to try and support them in understanding what are the barriers to them doing that, to try and make sure that we can actually get 100% coverage, as you say, for the benefits of the patients in those practices.
Because yes, it's kind of quite confusing as a patient to, you know, when you hear all about Footfall from other people in your network, and then you go onto your local practice and you go, well, where is it? It's not there.
And sorry, Doris was just asking about patients being disadvantaged with regard to those practices that aren't yet signed up to Footfall. Just explain that we're still working with those practices to try and bring them on board. I didn't know if there was anything else you wanted to say about that.
No, that's exactly right. We are still working with them to implement either Footfall or another online consultation system.
Thank you. Are there any other questions for Anne on Sorry, Judith.
You're unmuted, Judith.
No.
Not coming up.
Can anybody repeat it? Sorry. Sorry, I think Judith can't.
Ollie, would you be able to try, please, because you were the host of the meeting? Doesn't look as if we're able to, and it looks like she's having some Wi-Fi and connectivity issues, Doris, I'm afraid.
Yeah. Judith, you're unmuted.
I've definitely had technology problems today, and it's been quite tricky to follow some of the meeting in terms of listening. My question, if it can be heard, was really down about the NHS app. In terms of
Judith, I'm not getting that.
And therefore, what is proposed or planned in terms of comms to push out and encourage people to take up that app?
Okay. So the NHS app uptake really soared during the pandemic. We are at the highest uptake in the eastern region, but that's still not great. It's just below 3% of the eligible population, around about 27,000 people. But it's almost 20,000 more than before the pandemic. So people clearly have turned to it as a way of accessing healthcare, which is great. You're absolutely right to mention it, actually, Judith. And I think just going back to Tracy's question, in the context of things like repeat prescriptions and more routine access, some patients are using Footfall for that when they could be using the NHS app instead, or online services. So we do have a plan to work on comms to encourage patients to use the app or use those different methods. And some of that will be via Footfall itself. So if you choose to request a repeat prescription, people will get messages encouraging them to sign up for online services or to use the app. When patients can go back into practice, then there are things we can do there with the displays that they have in practices. We can use the MJOG app, which we've rolled out everywhere as well, to send those messages proactively to patients. But that's all we've got planned currently. If you can help us think of anything else, we'd be very grateful.
Thank you very much, Anne. No doubt Healthwatch can contact you offline with any suggestions on that one.
Yeah.
I hope that answers your question, Judith. It was quite difficult to hear bits of your question earlier. So are there any other questions for Anne? No. Thank you very much, Anne, for the update. It's very helpful summary of all the things that have been going on with you and your team.
Thank you very much.
Thank you. Move on to the prescribing update. Michael, the floor's yours.
Oh, thanks, Chair. Just before I start, actually, Terry raised a point about COVID vaccination earlier. I probably should have answered it at the time, but I thought I'd wait till my paper. But some of my team's involved in the COVID planning, and the vaccine is stored in dry ice and vapor phase nitrogen for for prolonged storage, but on the when it's delivered at standard fridge temperatures and will keep for up to 5 days at standard fridge temperatures. So once they're delivered out to GPs, generally we'll talk about 4 days shelf life of the product in standard GP fridges. Just thought I'd mention that because that is a key point. Yeah, we don't have fridges that go down to -90 in GP practices. That is true. Okay, prescribing paper. So one thing that was raised last time was the number of practices that had signed up to the PQS. We've now got 91 out of our 105 practices. So that's improving, and we're going to be nagging some practices just to point out that they do need to opt in this time. Clearly, practices might be under a bit of pressure. So at the moment, but we will be working with practices to see what indicators can be achieved during this time. Section 2.5, I've just mentioned the price concessions and NCSO. So 3.6 million is the effect of cost pressures on drug pricing year to date, estimated to the end of October. And there are 3 key drugs. I think I mentioned one of these last time, sertraline, which is a nice recommended drug for anxiety, which usage has gone up during COVID, and the price has gone up very significantly because of a shortage which triggers a price concession from the Department of Health. So that's cost us 1.5 million. Edoxaban is another key one, which is one of our preferred DOACs. So that's the alternative to warfarin, and there was a big move during the early days of COVID to get people off warfarin onto edoxaban, because you don't need as many blood tests throughout the year. You still need blood tests. NHS clinical commissioners are talking to the DH about clawing back some of that those cost pressures. I think Jason is hinting that they have been factored into some of our funding going forwards, which is interesting. Self-care. So I said I'd focus on self-care this time, and I've added a few bits of data around self-care. So Self-Care Week is next week, 16th to 22nd November. We will be sending out the usual press releases about it, and there might be something in the media, although other stories may be taking precedent. It's just a guess. So there is a wide variation, and the LMC, when I sent out the paper, did rightfully ask, have you mapped this against deprivation? And I did map it against deprivation, and hopefully you all saw the scatter plot, which shows that there doesn't seem to be any correlation between deprivation and spend on self-care. You would imagine that areas where patients are in a more deprived situation, that GPs might prescribe more self-care, and that would often be appropriate. But there didn't seem to be any particular correlation. Some high deprivation areas had low spend, and some had high. In one of the bits of data I put out on Appendix 1, for instance, so there's our top 6 practices by spend. So this is spend per 1,000 patients per month on items that could technically be purchased over the counter. So we've got Sheringham, Grimston, Burnham, Heacham, Litcham, Stalham at the top. And I believe all of those are dispensing practices. Some do have access to pharmacies nearby. Some of them don't. So just for interest, the Norfolk and Waveney is fairly average. I've included a heat map in Appendix 1 of spend. You can see there's some significant red areas, but there's also green areas nationally. And the things that are most stick out in self-care spend is pain, which is where paracetamol goes. And clearly a lot of paracetamol is justified if it's for a long-term condition, because it's a better alternative to other forms of pain relief, which might include opiates, for instance, and other drugs we'd prefer people not to use, perhaps. Dry skin. So there are some things we can do with dry skin, perhaps moving to more cost-effective emollients, or if it's classed as normal dry skin, asking GPs to give cell care advice, etc. Dry eyes, and then hay fever, vitamins and minerals, and indigestion are our main areas in self-care spend. I did a graph, as you see, of the characteristics of the practices in terms of spend per 1,000 patients, and UEA is at the bottom, which is interesting. That's quite an unusual population who perhaps have fewer self-care needs compared to practices at the other end. On moving away from self-care, dependence forming medicines, I'll just mention those. So we're still improving on opiates, gabapentinoids. We're remaining a bit flat this month. Hypnotics and anxiolytics. So on below section 4, I've just added for information the trend. So you can see that we are in an improving trend, but we're still third worst nationally on that. But the darker blue line is the national average. So we're moving towards it very, very slowly. And this afternoon there is our first meeting of the Dependence Forming Medicines steering group is going on with some high-level input from various stakeholders to talk about developing a strategy, a unified strategy across the ICS, the STP, across all stakeholders to work out, particularly with hypnotics and anxiolytics first, a way forward to work together rather than attack things in a piecemeal manner. So there's some work going on with there. Antibiotics, not much change, one slightly above national and one slightly below. Comments welcomed.
Tracy?
Yeah, hello there. Just in respect of the surgery, that's quite a staggering increase, really, isn't it? And I guess if we're prescribing more, certainly with the first lockdown and now going to the second lockdown, it's likely to go up again. And I think perhaps the impact on that is not seeing people face to face as well, where we can do a bit more kind of supporting, reassuring. And I wonder whether the impact of the wellbeing service also not doing face to face. So that's another impact on perhaps, some of that primary care prescribing we just might need to consider going forward. So that's my first question. In respect of self-care, I know probably about a couple of years ago we had a really big campaign. I'm just wondering if when we had that campaign, did that actually make a difference? And have we kind of reverted back a little bit to some poorer prescribing potentially in that respect? And again, I think it would be reflected on that we're not seeing people, and perhaps people aren't getting out, those shielded patients who might be prescribing more things because they're not out and about and able to purchase things during the pandemic. So that's just a consideration how we might want to consider an approach to that as well.
Yeah, on the second point, self-care, it did. There is a national downturn in spend on self-care. Within our own practices, certain areas were quite significantly more effective at reducing spend and being more engaged in the process, but more engaged practices did quite well on this, and other practices didn't do quite so well on it. So there is a big variation, certainly in terms of self-care. So it did have an effect, and it is going down nationally. In terms of anxiety, we did talk about prescribing leads, maybe having a session with possibly our mental health lead GP on alternatives to prescribing sertraline, because NICE chose sertraline in its guideline at the time because it was the most cost effective. It's quite effective, and it was very cheap at that time. It is no longer a cost effective treatment, so we'll do a bit of a training session with a mental health GP in the near future to do a tailored version of the NICE guidance, but by that time the price might have dropped, but we have got that planned for the near future.
Thank you. Kathy?
Thank you. Just on the self-care agenda, personal experiences. My father's terminally ill, so he uses a lot of morphine, but I buy his paracetamol because I'm aware of the cost. And then recently I bought some of his skincare products and found out the carers who are provided through continuing healthcare will not use anything that's not prescribed by the GP. So caused a huge hoo-ha, and then we had to go back to prescribed products. So I wonder whether there's some kind of inbuilt barriers within the system to actually driving the self-care spend down as low as it needs to go.
That's interesting. It probably means that carers haven't been signed off as being competent to administer homely remedies. That may be the care. If you email me the care providers' details, we'll look into that. It may just be their policy. Their administration's policy needs a tweak, because most carers will administer medicines that patients choose to take.
Okay, thank you.
John?
Thank you. Just on the self-care area again, I'm just conscious of the numbers there, Michael. If simple math serves me right, if we were to just reduce our spend to the national average, we would save about getting on for £400,000 a year. And at the moment, we've got inequity across the patch and variation, because in some practices, patients are appropriately paying for their medications, and in other practices, they're not, is my understanding, which may be broad. But I suppose just wondering what more we can do. So there's public messaging campaigns, great, but there's something presumably about those practices that are significant outliers at the top end.
Well, there is. I mean, some don't have good access to pharmacies, I mentioned. So they're it's difficult to say go to a pharmacy because there isn't one nearby. Although some of them do. But a lot of remedies you can be purchased over the counter at at supermarkets, etc. That is something that we need to work on another strategy for, and maybe for our prescribing scheme next year, in areas when we did launch 2 years ago our drive to appropriately signpost patients to appropriate self-care. We did launch an indicator and request that practices aimed for at least a 10% reduction in spend, and provided some training and posters and leaflets for patients, and that was more successful in those areas certainly, and that did provide an impetus for practices to do something about that. But there's certainly apparently an issue with 1 or 2 dispensing practices who may not have good access to pharmacies, and may not can't actually sell products. There is a thing I have mentioned in the paper called the Community Pharmacy Consultation Scheme, which will be launched at some point in the near future, and GPs will be able to refer patients to a community pharmacist for a consultation around minor ailments, and that will usually end with self-care advice, etc. Not necessarily selling a product, but possibly selling a product, and the pharmacies will be paid for that. But that's not such a good thing for some of the dispensing practices who don't have access to pharmacies again. So that is there is some inequity there. Not sure if that's answered your question fully. We do need to have a strategy to try and move the 2 ends, or the higher end sort of lower, so we've got some more equity here, definitely.
Maybe that's something we can have as an action offline to
yes,
come up with a practice specific thing, and also just link with that, if I may, just double checking my understanding where you're highlighting issues with dispensing practice, Michael. Is that an issue to do with the conflicts of interest that are woven into the structure for dispensing practice, if you like, or is it because of by into the fact they're dispensing, that means there is no community pharmacy nearby, and therefore it's the issues that you've outlined?
Well, both certainly. So there's less access for patients to buy slightly more than basic medicines that they could get from a supermarket, etc., corner shop. But dispensing practices will, they will make a small amount of money. It's not a vast amount of money on self-care items, so there is less incentive for them not to prescribe. Certainly, so there is a bit of a conflict there.
Okay, thank you.
Yeah.
Is there a correlation in the self-care between the age of the patient list and the amount of self-care prescription? Because I'm kind of, I think when you get to a certain age, you get your prescriptions for free. And is there a bit of patient education going on as well?
That's an interesting one. Okay, I can run some data on that. I don't know the answer to that. I suspect where in areas of more deprivation, most patients don't pay for prescriptions in areas of high deprivation. But there is already that variation. Some, as I've said, and you can see in the data that some deprived areas, practice populations have fairly low spend on self-care, and some have much higher. So that would seem to indicate that free prescriptions isn't necessarily an issue. It's more about behaviours and thresholds at which GPs prescribe or nurses prescribe, or pharmacists, and whether the preparedness to have a conversation about sending somebody off with self-care advice or to go and purchase something. I think it's possibly those sorts of behaviours and conversations that are the key thing in terms of controlling, and the preparedness for the practice to engage with the self-care agenda, which ultimately, as you more educate your population, will give you dividends, because you won't get so many patients coming back with hopefully minor ailments, and if they use their pharmacy appropriately, anybody with minor ailments with what they call red flags will be appropriately sent to their GP. So there is a kind of sweet spot of that kind of process, if that makes sense.
I think just, from my own personal experience of looking after elderly parents, that sometimes they're just on a repeat, and
yes.
if the pharmacy delivers, it's all part of that package that arrives to the door
Yes.
without the patient even ticking a box.
Yes, that's something we're well aware of, and certainly we have some in parts of our of the patch. We have, for POD, for instance, which seeks to prevent those sorts of things from happening. But where pharmacies do what's called managed repeat, they do patients tend to get more medicines than they need often. Yes, we're well aware of that. So it's about not having those on repeat. Certainly, that's another issue altogether.
Thank you. Karen, you're on mute. Yeah, that's better.
Can you hear me?
Yep.
Yes.
Okay. Sorry, I've got terrible feedback. Really just to say that I was very, very keen that we reduce the variation, simply because there's an awful lot of practices that have worked incredibly hard to achieve this. And I just feel that it's disincentivise people if others aren't actually making steps to promote self-care. So I know that I was very directly involved in Norwich and personally had to write to a number of people. And once you go through that pain, you set the behaviours. But I'm hoping we get that right. I hope you can hear this because I'm not sure you can.
Yeah, that's fine. Thank you. Any other questions, comments, Michael? Bill? Bill, did you want to come in?
Oh, thank you. Sorry, I lost you for a second. Yes, we talked about those practices where community pharmacy wasn't available. Is that a large percentage, or is that just one or two practices? Because if it's a very small number, it would be worth pulling them out of the stats so that they don't affect the overall picture.
There's a few in rural areas where they don't have good access to pharmacies, for instance, because the way dispensing practices work, for instance, Heacham or Sheringham, so the practice can't dispense to anybody within a mile of the pharmacies, which are in the towns, but they can dispense for all the outlying areas. So there's quite a lot of villages, who attend the surgery, and they get their medicines dispensed, and the GPs, as opposed to the pharmacy, makes some remuneration and income from that. So it's difficult to separate them completely. If you, for instance, places like Litcham, the nearest pharmacy is probably 10 or 12 miles away. We could sort of color code them as ones where pharmacies are greater than 10 miles, one where they're 5 miles, one where there's a mixture. I'm not sure that would add much, to be honest. It is about, to a certain extent, the behaviours and the willingness to have conversations and etc., and possibly some of the conflicts in prescribing or not prescribing.
I was just thinking about where there are some practices that have been very successful.
Indeed. Yeah.
And if there is a practice that is a long way away, then there's no point in us or the system continually having a go at them. I'm just thinking that the Health and Wellbeing Board do the pharmaceutical needs assessment.
Yeah.
And that sort of data with the colour coding would be very helpful for that other piece of work.
The LPC are well aware of the issue. North Norfolk is, certain areas of North Norfolk is particularly poorly covered by, a good coverage of pharmacies. But these days there isn't much incentive for many pharmacists to open another branch in North Norfolk, because the income from it is not that great. But self-care is not about necessarily a pharmacy, although a pharmacy would be useful on the doorstep. It's about people having a basic medicines cabinet, just as some painkillers, some indigestion remedies, some anti-allergy preparations, and some maybe a cream or two in their armamentarium next to the coffee and tea. Maybe, I don't know. I'm just speaking from personal habits. But so you don't necessarily have to visit a pharmacy. You can just keep some in stock for when you need them, and hopefully not bother your doctor if it's a minor ailment, and use the NHS app to get advice if you're concerned that it might not be a minor ailment, or 111, etc. So it's changing behaviours rather than, I hate to say, wasting a GP's time, because it probably in some circumstances definitely isn't, but it's just changing those behaviours, and it'll pay practices dividends down the road if they engage with self-care. But yeah, this is something that we do need to have a strategy on and aim to reduce appropriately.
Thank you. Judith, did you want to come in?
I'll be heard. I don't know. Just really something Michael did touch upon just now, that whilst there are issues with some people having access to community pharmacies, many of these things are available in corner shops and in supermarkets. It's not just so. I mean, I'm not saying there aren't issues with community pharmacies, because we know there are in some locations, but these are items that are available readily in many shops. That's all I wanted to add.
Yeah.
Thank you, Judith. Tony?
Yeah, thank you, Michael. It's very interesting, and I'm very interested in the way in which you've gone about this. My question is there any correlation between the way prescriptions have been written over the last few months, due to the fact that a lot of people living in the rural areas aren't having such easy access to supermarkets? They're having to shop online, or people are having to collect the shopping for them, and they're not picking up the paracetamol or the E45 or the aqueous cream that they would normally perhaps pick up in the supermarket, that now they're asking the GP to prescribe for them. I just wonder if there's any correlation.
I hadn't looked at the trends. There was probably a slight increase in all prescribing at the start of the first wave. I haven't specifically, sorry, get my words out, looked at self-care. I'll perhaps come back to you with that one in the next day or so, and just see if there is a trend there. So I don't know is the answer, I'm afraid. I'll look at it.
Thank you, Michael.
Okay.
Are there any other questions for Michael? No, thank you very much, as usual, for your informative report. We move on to the PCN development, which is a verbal update. I think, Fran, are you taking this one?
Yes, I am. Thank you. This is the South Norfolk point of view, and hopefully Sarah will be able to share the slides with you. I'm here today with Mandy Wegg, who's the Senior PCN Development Manager. So we will go through the slides between us, and then hopefully answer any questions that you've got. So if we can have the next slide, please, Sarah. Hi, Sarah, can you move the slides along, please?
Sorry, I'm having a bit of a technical issue.
Okay, shall I try and share mine?
Is it going now?
They're going, okay. Yeah, that's great. Thank you very much. So the first slide shows the South Norfolk place with its 4 PCNs. It's quite a spread out locality, as you can see. And
Sorry to interrupt you, and I appreciate you trying that, but is it possible you could put them slides on full screen, because they're coming up on my screen about 2 inches by 1 inch.
Is that possible to do, Sarah?
Oh.
That's great. That's come up now. Thank you. So if we go to the second slide. that better, Tony?
Go on, carry on. I'll make do. Don't worry.
Okay, thank you. So the South Norfolk area covers approximately 240,000 patients. The rurality of it and the spread out nature of the geography does make it quite difficult when we look to develop hubs for service delivery, although it has happened in a few areas as a response to the COVID, the first COVID outbreak. I think the sizes of the PCNs vary quite a bit, which pose its own challenges. And some of the other challenges we have is the extent of our borders. So some patients to go to QE for acute care, many to West Suffolk Hospital, the NNN, and even on the kind of the extremities of the borders, patients could find themselves in the James Paget if they become unwell. So we have a lot of system partners and a lot of different pathways that we have to link into for the benefits of our population. I think for me, coming new into post, I've been in this post probably about 18 months now. I spent the first 6 months, it seemed to me, forever in the car driving around South Norfolk, and that's when you fully understand the issues that we face when looking at service delivery. And I think one practice I visited in particular had patients tipping out through their door because it was the day for the weekly bus from one of the outlying villages, so that once a week they can get a bus to their surgery. So it can be quite stark in some areas. Okay, so we go to the next slide, please. And Mandy will take you through the next few slides. Thank you.
Okay, so we've got 4 PCNs in the South Norfolk locality. The first being, well, in no particular order, but Mid Norfolk PCN serves around 50,000 patients, and it's got, again, a wide geographical rural area and quite a significant amount of deprivation. They've been the pace setters within Mid Norfolk around care in care homes. So they've got a multidisciplinary team which involves geriatricians from the Norfolk and Norwich. And this is now a new contract for our GPPO. The recovery and recruitment plan was designed to stabilise the practices, and this was the tack that they've taken was to set up a visiting nurse scheme, and it's been very successful. You'll see the middle map on here is the shape table, which is very crude. So it doesn't show the geographical boundaries, but just the shape within the practice within the area. So from the population, and you'll see in the next 4, there's 3 further PCNs, that generally they follow the same sort of spread of patients. And you'll see with the flu vaccines now covering from 50 to 65, a huge amount of the population sits within that middle area here. Sarah, next slide, please. So the Kets Oak PCN serves around 60,000 patients. So it's the Wymondham area, Hingham, and Humbleyard. So Humbleyard has practices in Heatherset and Mulbarton, but also just on the city limits of Cringleford. So they've all been working through their priorities and workforce and the ARRS roles, the additional recruitment funding is provided by NHS England, and it's been quite a challenge to recruit to the roles with the available specialisms. Next one, Sarah, please. So SNP is the largest of the PCNs, and it serves around 87,000 people. Since the Attleborough has moved from Kets Oak PCN to SNP, so the map here, and you will have the slides later, actually spreads further to the left because it now encompasses Attleborough. There's 18,000 patients in Attleborough. It's the largest practice of all of the areas. Again, they've been looking at their ARRS spends and are concentrating quite heavily on care coordinators and pharmacists. The options for hot hubs is very limited. The SNP area covers from Attleborough, including Loddon, Pulham Market. So it's quite a big area, and it's thinking that possibly the hub could be in the Long Stratton area, as close to the middle of the area as we can. But it does present challenges for patients travelling from, say, Attleborough to Loddon is an awfully long way to go. They're taking an aggregated approach to improve early diagnosis of cancer, and each practice, reviewing their practice packs, have decided on their own local actions. Learning disability health checks are also underway, and we're also working on aligning the learning disability register. Next one, Sarah, please. Now you'll see the shape of the map for Breckland PCN, is extremely different. It's got a younger demography, and it's also got a high level of varied ethnicity. There are 4 practices within the area: Grove School, School Lane and Watton. You'll see the map, excuse me 1 second. Fran, could you take over, please?
Yes, I'll continue, Mandy. The Breckland Alliance, they are, I think I should have said at the outset, the South Norfolk PCN areas have worked together as localities for many years, and then recently became PCNs when that changed. And in Breckland, they have formed themselves into an alliance with shared management and the ability for staff to move between practices. They've also recently been signed off from NHS England in terms of the Watton Recovery Plan. Those of you who've been around a while will remember this was quite an issue 5 years ago, and I have to say they've done very well. They've made great improvements, and the acceptance of responsibility from a managerial point of view, and more importantly, clinical leadership within that practice has improved the situation greatly. So much so that they have recently been able to recruit to a few of their GP posts, which was very good. And they've also, they're quite innovative. So one of their partners, their practice partners, is a clinical pharmacist. So I think that's turned out very well for Watton through that programme. Can we have the next slide, please? I'll carry on until Mandy recovers herself. So if you're looking at the PCN ethnicity profiles, I think it's quite clear that most of the PCNs mirror a lot of the situation we see in the rest of Norfolk, apart from the Breckland Alliance, where there's a more diverse mix there. And I think I think the last of the combined South North Norfolk PCCCs I came to, they spoke about their translation services and the cost of translation services in this particular area, and I think this bears out, it supports why that's necessary, where the most common non-English language being spoken is Portuguese. Are you able to continue, Mandy, or shall I?
No, I can carry on now.
Okay. Next slide, please.
So the next slide is around the deprivation, and we know there's many houses of multiple occupancy, and certainly with the recent COVID outbreak in Watton, it's been an issue because of the amount of shared accommodation. So South Norfolk's average index of multiple deprivation score is 15.9. In 2015, 26,000 people in South Norfolk lived in areas of deprived housing. The top 3 practice deprivation scores match the Breckland profile in its schools, School Lane PLS, the two contracts, the Watton practice and Grove. You see also from the map, if you can see the small font there, the lawns and parish fields are in DIS. They have a sprinkling of deprivation. Toftwood, Theatre Royal, Orchard and Elmham in the mid-Norfolk Dereham area, also, but predominantly it's around Watton, Shipton, Grove or School. So certainly the deprivation and the multiple occupancy homes has been an issue. Next slide, Sarah, please. And the deprivation type is broken down. Health deprivation has 13,054. Barriers to housing, again, just over 13,000. And income deprivation affecting old people. So it isn't just the young, it's a mixture of younger individuals and older individuals. Again, the dispractices figure and the lawns and parish fields are in the same practice area, Dereham, but again, Watton, Shipton and Grove, and a little bit of Hingham, which borders Watton, are also amongst the 3 high-ranking areas for deprivation. Brian, did you want to take from the next one, Sarah, please?
Yes, please. Okay, so this is a little bit of sort of an internal stakeholders map and shows how we organise ourselves in South Norfolk and how we also link in with the rest of the CCG. And these gatherings have been invaluable over the past 6 months. And I think we've all got quite accustomed now to working virtually, and they work a lot better. One of the key meetings we have is we have an evening call once a week with all of the PCN clinical directors and the lead practice managers, the locality director from NCH&C, clinical advisor. And that started off as a response to COVID. We had them daily in the first wave, and we've settled now on once a week, although I can see that with COVID vaccine and all of those things coming, that might change. But that is an invaluable meeting just to catch up with everybody across South Norfolk and for learning and sharing as PCNs develop different ways of working. Next slide, please. So this is shows where we are in terms of our partners across the LDG. We have a very well attended LDG, and we try and keep the agenda as diverse as possible. So I think next week we've got something to do with foot and ankle pathways to inform the primary care colleagues there, but also somebody from public health coming to talk to us about different tools to help us with our health inequalities work, something about care homes, and then Breckland Council coming to talk to us about their plans coming up. So that's always well attended, and it tends to be quite a lively meeting, which is really good. Next slide, please, Sarah. So these are the people, if you're looking at the South Norfolk population as a whole, we couldn't get all the partners we have to link in with on a page. So it just shows you that with our borders and with the kind of more spread out nature of our population, there are a lot of people involved in supporting the population of South Norfolk. Next slide, please, Sarah. So some challenges. So flu, COVID, the COVID vaccine programme is going to be a challenge to us. I think managing public expectations is a Norfolk and Waveney challenge. And all of our providers have workforce issues, either due to the need to quickly scale up with some roles. We've got some money for roles that we can't recruit to quite because the people are not there. I think the impact of COVID and testing and the need to isolate has impacted on all providers. And also particularly the practice capacity for staff. So staff requiring to actually be in work, but also it takes more time to do things differently and for staff to get used to new ways of working. We have a few key estates challenges across the patch, and thank goodness now we have a primary care estates team who are supporting with that. And then every day it brings its own challenges. Just as we've been speaking, I've just had a notification of an IT outage in one of the practices.
And I think this was something the team wanted to put on, because Roy Weston, who's our AD for contracting, says never underestimate how important it is to be able to get a bus from nearby to a hospital. And I think if you were to speak to many of the people in our villages in South Norfolk, you know, to get to places is a big challenge for some of them. Next slide, please. So what have we achieved? Well, I think we formed our new PCN development team remotely. That's gone very well. In fact, 3 of my team I've only ever met once, and that was at their interviews last February. And so their induction has been unusual, to say the least, but they are very good and doing very well. We've quickly picked up our relationships with primary care colleagues and other external stakeholders. We've got a contract for visiting nursing teams in Mid-Norfolk PCN. And I think the team highlighted in trying to sort out our improved access issues that there was a national problem with System 1, GP Connect for System 1 and EMIS, which is now being resolved as a result of that flag. We supported primary care colleagues during the first wave of COVID-19, and I think can't underestimate the impact on primary care and how hard primary care worked through that to be able to deliver services for their patients. We, as our other ADs in other areas, contributing to the new financial dashboard and piloting the mental health practitioners in Breckland. I think this is a bit deja vu, because I think I said that this time last year, but it is now actually happening and has started. And then largely through the efforts of Olga Chiriani, who's the head of integration and partnerships in the team, we developed the care home alignment tool, which has been used in recent conversations about implementing the care home LES. I think that's my last slide, and then we'll try and answer your questions.
Thank you very much. That was very helpful. If Sarah could just take the slides off the screen so I can actually see people, that would be great. Thank you. Are there any questions for Fran and Mandy from anybody? Sorry, Tony. You're still muted. No, you're still muted. Yep, that's it. Sorry, we can't hear you.
Can you hear me now?
Yeah, that's better.
Sorry. Thank you, Fran. Very good presentation. I thoroughly enjoyed it. Very impressive. You mentioned Waveney once, but nothing else. Is Waveney not included in this?
No, Waveney's not in South Norfolk.
Thank you.
Hein?
I agree. It's an excellent presentation. So well done, Fran and Mandy. And a question, a comment we often pick up is the capacity on the clinical directors, who I think on paper spend 1 day a week on this. So for your neck of the woods, what's your assessment? Ideas on how additional support can be provided if needed?
I think having that weekly call where the clinical directors come together with the clinical advisor helps enormously. And they're very willing and able to share any information that might support. More and more, I think, as the pandemic has developed, they've been pulled more into practice work, and so find it less easy to create some time. We tried to get a clinical forum off the ground, but actually time to meet just didn't happen. So the 4 CDs, Hilary Byrne and Julie Glenn, who's a clinical advisor, have agreed to have a virtual clinical forum. So if we've got anything as a team we need some clinical input on, then we just send it, pop it out to an email, and somebody will come back to us. But if it's something urgent that we need their advice on, they will make time for us.
Thank you.
Any other questions? No, thank you very much for a very helpful and informative presentation. And Sarah is going to send out the slide pack to everybody after the meeting. We look forward to seeing you again before long.
Thank you very much. Bye-bye.
Thank you. There are no questions from the public that I've been made aware of. So that's the last item on the agenda for today for part one of this meeting. Thank you all very much for giving up your time this afternoon.